Hey, we are back. Good morning from the office. I'm Rick, your host this morning. We're going to have the All-Star panel coming up, but this is our long-awaited segment with Ask the Doc. No, this is not Dr. Whaley. Dr. Whaley is traveling this morning in Russia with his charming wife Jane, a member of the All-Star panel with myself. Justin comes to us this morning. Justin Nicholson, a nurse practitioner, a colleague of Dr. Whaley, and he comes to us from the Georgia Cancer Specialist,
yes,
affiliated with Northside Hospital.
That's it.
I don't know why I've got a mental block about that, Justin. I'm telling you.
That's okay.
But anyway, he will fill in for Doc this morning, and I told him I was going to throw him a curveball, and I'm going to throw him a curveball. People out in the public do not realize when I say nurse practitioner or I say physician assistant, just for a little knowledge out there for you that are tuning in, those terms, sometimes those people vie for the same jobs.
Mm-hmm.
They are very synonymous, I think, in the marketplace, in the medical profession. You don't know what an invaluable service a guy like Justin and PAs provide out there. They're a stopgap measure, if you will. The docs are the MDs are so busy that these two levels of education have become so popular that they are able to take a lot of the load off of the physicians. Mm-hmm. And correct me if I'm wrong, Justin. Mm-hmm. Your education level is such that if you're a nurse practitioner, you know, you take an education discipline to the nursing side, whereas a PA would take it to the medical side. And a lot of times they'll take a job, he or she will take a job that is surgery related, mm-hmm, things like that.
Correct.
Will you care to expand on that and just give a little bit of background to that level of education, what services you're able to provide?
Sure.
That that maybe that are on the same level as a doctor?
Oh, okay. Yeah, sure. So, nurse practitioners and physician's assistants both, they have what's called prescriptive authority in the state of Georgia. So, both of those.
So you can evaluate a patient,
mm-hmm,
and you can determine if there's a condition, mm-hmm, that you've determined is in need of a prescription. You can write without any other doc looking over your shoulder, basically.
Sure. Yeah, to some extent. You can evaluate, diagnose, manage. Nurse practitioners and I believe PAs both in the state of Georgia, they can't prescribe certain medications like Schedule 2 drugs. Schedule 2 drugs. You can prescribe Schedule 3, but not Schedule 2.
Schedule 2 drugs is something analogous to like a
an opioid.
Yeah, an opioid. Okay.
Yeah, hydrocodone.
Right. Okay.
Stuff like that. But I mean, there's very similar, synonymous things between a nurse practitioner and a physician assistant. But the difference is, as far as a physician assistant, by definition, they have to be with a physician at all times.
It's kind of like a real estate agent coming under a broker's license, if
Sure.
you will.
Yeah,
Okay.
Yeah.
I'm just trying to paint a picture here, folks, to show you what how these folks operate in the medical community.
Mm. Some states, nurse practitioners now have full practice authority where they can practice independently. That's not Georgia, but mostly in the Midwest, Northwest, some of those states.
You're a hometown guy. You
mm-hmm.
grew up in Ducktown.
Yes, sir.
Where did you do your education?
I have a degree in biology from Augusta State University in Augusta, Georgia. After that, I went to nursing school at Kennesaw State University, and I decided
great nursing school there.
It is. It's fantastic. and I received my nurse practitioner degree at University of North Georgia in Dahlonega.
I got you. So is that the highest level that a nurse can attain?
No. So my nurse practitioner degree is a master's degree.
Okay.
You can go further with a DNP, which is a doctorate of nursing practice.
I got you.
Yeah. Most of the people who receive a DNP, they either teach or it's a little bit different than a PhD where you go into research. DNPs usually teach, or I mean some practicing nurse practitioners are getting their DNP.
I got you. So I just you know, a lot of times we walk into a doctor's office and you know, you're expecting to see the doctor, then all of a sudden someone says, well, you're going to see the nurse practitioner. You're going to see the physician's assistant, and you sit there and you roll your eyes. Don't roll your eyes, folks. These people they perform an invaluable service to take the pressure off the docs and cut through the red tape, basically. And, you know, a lot of times if I'm going to my orthopedic person, I'd rather see the PA because they get right in, they tell you what's going on, and you don't have to sit and wait for 45 minutes to an hour. So, I'm trying to throw you a bone here
I appreciate that. I do.
Because you gentlemen and ladies, you know, you provide a great service in the medical community.
Thank you.
So, anyway, I didn't mean to throw Justin a curveball, but I did anyway. So
okay.
Let's get into the questions. All right. So the question number one. Not me, but I'm a 58-year-old woman, and my cholesterol has been high. My cholesterol was high on my most recent labs, and my doctor wanted to put me on cholesterol Excuse me. It's never been high. The cholesterol has never been high till she went and did a blood panel with the doc, and now my cholesterol was high on my most recent labs. My doctor wanted me to be put on cholesterol medication. Do I really need to start taking a medication?
It's a good question. We don't really have as much information as what we need to make that determination.
Are we okay on sound? Yeah.
So we need to know some other things, like does she have high blood pressure? Does she smoke? Does she have any history of diabetes? Because all those things play a factor into the decision to start somebody on a cholesterol medicine. When I was in school, the American College of Cardiology came out with a calculator, if you will. And what it is, you can put in information to decide if somebody needs a cholesterol medicine. Before that, there was an algorithm, and it was really hard to follow.
It's like using a slide rule. Huh?
Yeah. If this, then this. If this age, then this. So this calculator make it really easy to decide if somebody needed a cholesterol medicine. And so I took the liberty creating some information to see if, to really show how this calculator works. You can use it at home. It's free. All you have to do is search ASCVD risk calculator.
Say that again.
ASCVD, which stands for atherosclerotic cardiovascular disease.
Okay.
Risk calculator. And on the first slide that I have today, under inputs, it shows an age. She's 58 years old.
Okay.
Total cholesterol, 268. So her cholesterol is high. We want that below 200. HDL cholesterol, and we know that is the good cholesterol.
That's the good one.
That's the good one that helps.
The HDL is the good. The LDL is the bad.
Correct.
All right.
Correct. So we want the HDL is really as high as we can get it, above 40, for a woman above 60. LDL is bad cholesterol. We want this below 100, and hers is 172. Systolic blood pressure, she has a little bit of hypertension. 58 years old, we want her systolic blood pressure below 140. So she has a little bit of a high blood pressure issue. She doesn't have diabetes. Former smoker. She's on a treatment for high blood pressure. She's not on an aspirin. And she's not taking a statin medication for cholesterol. Okay.
Statin medication is a cholesterol drug.
Yes, correct.
So you put those all into the formula.
Yes.
And magically it comes up with...
Yeah, so if you put all this information in on the next slide, it shows her current 10-year ASCVD risk is 8.4%. So what that means is she has an 8.4% chance of having a stroke or a heart attack within the next 10 years.
Oh, wow.
Yep. So, and also gives
That might be scary to look at. I plug my stuff in and it says I'm going to die on Thursday or something like that.
I put mine in personally.
Do you?
So, yeah.
Okay.
So her lifetime risk is about 50%, and then at the top it says optimal ASCVD risk is 1.9%. And what that means is if she starts a medicine, if she's required to or recommended to, and she does everything else that's necessary, such as weight loss, getting her blood pressure down, eating healthy foods, then her optimal risk is down to 1.9% of having a cardiovascular.
So it even plugs in a goal for you, huh?
Yeah, it does.
Do this and you can be this.
Yeah, and it also gives recommendations and treatment options. It's a great tool. So you see the information that's plugged in on that slide. And if you go to the next slide, say we need to start her on a cholesterol medicine.
Okay.
Okay. So if you look towards
what are a couple of the ones that you see on TV all the time? A couple of medicines that people will...
Crestor,
okay.
Lipitor,
Crestor, Lipitor.
Yeah.
And without screwing up your chain of thought here, don't those have a risk of liver impairment?
They do.
And so what should you be... What do people that are on cholesterol statins, cholesterol drugs, sure, what do they do to make sure that it doesn't have any liver impairment long term?
Yeah, so your primary care doctor, I'm sure they're doing this, but every 6 months you should have what's called a metabolic profile.
Okay.
Which includes some liver enzymes to be sure that your liver enzymes aren't being elevated while you're on the cholesterol medicine.
Okay.
That's a low percentage of patients that are on.
All right.
But there is that risk.
Yeah.
So
excuse me. Go ahead.
No, that's fine. So with the cholesterol medication, just starting that, she drops from an 8.4% risk down to a 6.3% risk with statin therapy. So I mentioned earlier her blood pressure was elevated.
Right.
All right.
142. You wanted somewhere around 140, 130 for a 58-year-old woman?
Yeah, below 140. 139 is okay.
Yeah.
So say we start on a blood pressure medicine. That drops her even further from an 8.4% down to a 4.6% risk of having a cardiovascular event, so a stroke or a heart attack within the next 10 years. Okay.
Now, tell me about, I've heard that cholesterol is something that you're susceptible to through genetics.
Sure, absolutely.
I mean, luckily, even though I'm a little pudgy here and there, I'm 71. I've never had a cholesterol issue.
Yeah.
I mean, every time they run a panel, I go, "How's the cholesterol?" It's fine.
Yeah.
It's well within the limits.
Yeah.
My parents never had any cholesterol issues.
Correct.
So I'm assuming that someone that's fit as a fiddle can. I used to work with a guy that used to eat just a turkey sandwich every day, and he would watch his weight, and he was fit as can be. His cholesterol was off the chart.
Yeah.
And that's because of genetics.
Sure.
Yeah.
My grandmother, she was thin as a rail. I mean, as thin as can be, and she had the highest cholesterol of anybody I've ever seen.
Really?
Yeah, and there's a fancy diagnosis for that, and it's called familial hypercholesterolemia, which means that you create more cholesterol than say an average person, because around 70 to 80% of our cholesterol is produced by our liver, because we have to have some good cholesterol in our
right.
body. And then probably 20 to 30% of that cholesterol is from our diet.
I got you.
Yeah. So genetics, you're correct, it absolutely plays a part in it.
I got you.
Yeah. So let's just kill this woman's day and say that she has diabetes too. Okay. All right. So with diabetes on the next slide, that automatically doubles her risk.
Wow.
So she went from an 8.4% to a 15.7% of having a cardiovascular event in the next 10 years.
Wow.
Yeah. So that just goes to show, when somebody has diabetes, they almost always get started on a statin medicine.
I got you.
Yeah.
I got you.
Yeah. So going a little bit further, there's treatment advice. So this calculator gives us a recommendation of what type of medication to start for this woman. Statins aren't all the same. There's low intensity statins, medium intensity or moderate intensity, and there's high intensity statins.
Is this a drug that you need to ramp up, or do you come right out of the box with whatever dosage you're gonna plant?
Yeah. So if this is my patient, I use this calculator, and if it recommends, like this slide says, moderate intensity statin, I start her on a moderate intensity statin.
I got you.
If it doesn't decrease her cholesterol, specifically the LDL, to the point that I want it, then you can ramp up.
I got you.
Yeah.
So, how does she, as a 58-year-old woman with high cholesterol, how does she ameliorate her situation? Diet?
Mm-hmm.
What else?
Diet, exercise. Exercise is the number one way to increase that HDL, your good cholesterol.
Oh, okay.
So making sure that you...
So get your buns out there and get
Yes,
moving, huh?
Absolutely.
Okay.
Moving. She doesn't have to run a marathon.
Right.
She doesn't have to be Dr. Whaley. But but if she starts walking consistently, daily, I will use one of his tactics to begin, say, 15 minutes a day, increase by 5 minutes a week per day. She's going to get her HDL up, and it's going to help her cholesterol levels.
Gotcha.
Yep.
That, I can't tell you how invaluable this information is to folks out there who may be suffering from, elevated cholesterol. Pay attention to what Justin is saying. Once again, we covered the nurse practitioner side. We gave a little shout out to the PAs out there. Mm-hmm. They're an invaluable tool out there to the medical profession. And if you're not seeing the doc, see one of these guys or gals. And let's see, should we go to the next question?
Sure.
Are you ready for that, or you got more to talk about cholesterol?
I'm ready.
This is a good one. My wife says I snore every night. You say that? My wife is in the background back there, wagging her head back there.
Yes.
My wife says I snore every night, and she's concerned that I might have sleep apnea. Should I ask my doctor about this, or what's the next step? And it takes one to know one. I'm not going to go any deeper than that. But talk to me about sleep apnea. You hear about, you see these people. Let's go out to breakfast, honey. Okay, we're sitting at breakfast. All of a sudden, you see this guy come in with these strap marks on his face because he's been saddled all night with this respirator.
Sure. Yeah.
With this machine on his face that I don't know what it's doing, but. Talk to me about sleep apnea.
Okay, so with sleep apnea, we have what's called fragmented sleep. Okay, and what I mean by that is that, somebody with sleep apnea, the back of their tongue kind of falls backwards, and it narrows their airway, so they don't get as much oxygenation or airflow to their lungs while they sleep.
Now, this is a mouth breather?
Yeah, this is a mouth breather. We're talking about obstructive sleep apnea.
Okay.
Yeah. So with that fragmented sleep, what I mean by that is that they fall asleep, they start snoring because that falls back into their throat, and they're not getting that good airflow. And our bodies are really smart, and they can recognize that our oxygen levels are decreasing. When that happens, it wakes you up just a little bit. Not enough to where you can say, oh, it's 2 o'clock, but just enough to where you can correct your breathing. That happens, you fall back asleep, and the cycle repeats itself. So it's not good quality sleep. And that's why you see, somebody with untreated sleep apnea, they feel pretty terrible during the day. They're sleepy all the time. They're the person that can sit down just for a moment and they fall asleep.
Right.
Yeah.
I can do that in the afternoon.
Can you?
Well, yeah, I got to take my 20 in the afternoon sometimes.
Yeah.
But so you're diagnosed with sleep apnea. Does that mean you have to do a sleep study?
Well, before you're diagnosed, you do a sleep study.
Okay.
Yeah. And there's a couple of different types of sleep studies. You can do one at home, or you can do one in a sleep lab. Yeah.
How do you do it at home?
So they have home sleep study tests.
Oh, they do?
Yeah, they do. Before,
We got sounds of the city this
Yeah.
morning. We got the food trucks coming in.
sure.
We've already heard the train whistle blow 3 times. But anyway, sorry.
So the in-lab sleep study, so where you go to perform a sleep study, that's always going to be the gold standard. There was a study came out about a year ago that said that they're pretty equivalent at determining diagnosing sleep apnea.
Wow.
So I give my patients the choice, whatever is convenient for them, letting them know that the gold standard is always an in-lab sleep
So
study.
you get patients coming to you that said, "I just can't sleep at night. I wake up tired." I hear that from a lot of people. I
Yeah.
wake up tired in the morning.
Yeah, I mean, it's America. We all work really hard, so everybody's tired. But if I see some of the risk factors, I start asking them about other things like snoring and such.
And is it preventable?
To some degree, yes. Yes, and we're going to talk about some of the things that you can't really help.
You
but,
go.
Yeah. Well, have you ever heard of a Dr. Colin Sullivan?
I am not.
Okay. Dr. Colin Sullivan is an Australian physician, and back in 1980,
Okay.
he discovered that if you provide continuous airway pressure, pressure to your nose or your mouth, these people with sleep apnea, they don't snore, they don't have as many apneic events where they stop breathing, and they don't have that sleep fragmentation that I spoke of. And he did this with a vacuum cleaner motor.
Eureka!
Yeah.
I found the cure.
He did. Pretty ingenious.
Yeah. Yeah. So what did he do? He just used a vacuum cleaner motor and and made a mask.
Made a mask.
Okay.
I think his was a nasal cannula, so he put it over the patient's nose. And it
Just
was,
like a 2-prong cannula.
No, I think it was more of a
So
a mask over the nose. Yeah.
fixed and it was
I don't have pictures of it. It was probably very rudimentary.
okay. It was 1980. What the heck?
Yeah, that was before I was born. So.
Yeah. Now you're dating me now. Go ahead.
So the guy woke up, felt amazing, the best he had felt in years.
Wow.
Yeah. So, but looking at this, well, the short answer to the question is yes. I think you should go see your doctor, see if you qualify for a sleep study. And looking at this table 3, here's some of the questions that we ask ourselves as providers if this patient needs a sleep study. So you're more at risk if you're obese, and you're also more at risk if you're what this word retrognathic. And retrognathic, and that's a fancy word for saying that your jaw, your mandible, is a little bit recessed. It's a little bit pushed back. Mine's actually like that a little bit.
Okay.
Yeah.
All right. Yeah.
Or
profiles encourage.
Yeah. Does the patient complain of daytime sleepiness, like you said, falling asleep in the afternoon?
Right.
Yeah. Does the patient snore, and do they have high blood pressure? So
those are all factors that contribute to
sleep apnea.
Okay.
Absolutely. On the next table 4, these are symptoms that I talk to either like if I had you and your wife was there, I would ask your wife, does he snore? And how bad does he snore?
She's back there laughing.
Yeah, does he shake the room, or is it just a quiet snore? Does he stop breathing? Do you ever witness him stop breathing? Or gasping, choking at night? Some of those are listed here.
Right.
Non-refreshing sleep. So when you wake up in the morning, you should feel refreshed. You should feel better. You shouldn't feel like you hadn't slept at all when you've had 7-8 hours of sleep.
Yeah.
So morning headaches, that's another big one. I have some patients complain of morning headaches. Yeah.
I've never heard that associated with sleep apnea.
Mm-hmm. Yep.
No kidding.
Yep.
All right.
On the next page, these are the things that I'm looking for to send somebody for a sleep study. So are they obese? Is their BMI greater than 30? Do they have a crowded or a narrow posterior oropharynx? So that's a fancy... That's a fancy way of saying that I can't see the back of your throat. If I'm looking at your throat, with a light, I can't see the back of your throat. It's really narrow. All I see is tongue and the roof of your mouth.
Okay.
Okay. The next is enlarged neck circumference. So I truly measure someone's neck. If they're complaining of some other of these things, I measure their neck. So for a man, greater than 17 inches. For a woman, 16 inches.
Do you refer them to an ENT?
Well, it depends. If they're wanting a home sleep study, I will refer them to an ENT.
Ear, nose, and throat doctor.
Yeah, ear, nose, and throat. If they're wanting an in-lab sleep study, I will send them to a sleep specialist.
Okay.
Yep.
All right. Are there any of those in the Blue Ridge area?
Sure. Yeah, we have an ENT at Riverstone.
Okay.
Yeah. We have the ability to do sleep studies at Fannin Regional Hospital.
Okay.
Yeah. So we do have that.
So when you do a sleep study, tell me about that. You go, you check in, you get your infamous plastic armband, and you literally just say nighty night, and they hook you up to
multiple things.
Multiple
yeah,
things.
Multiple things.
And then you're monitored during the night. Is that right?
Correct.
Okay.
So they do EEG. So you have some brainwave leads. You have an EKG to where they can monitor your heart rhythm, and they have a.
So it's pretty.
It's in depth.
Okay.
Yeah, it's in depth.
Nice.
The other things I'm looking for are associated conditions, like AFib is actually one of them.
Oh, really?
Atrial fibrillation.
Okay.
Yep.
So that's why they do the heart monitoring.
Yeah.
In that sleep study.
Part of it, sure. Yeah, part of it. And the next picture, I really like this picture because it shows how the back of your tongue actually falls downward and blocks.
Oh yeah,
it
blocks that airway.
Yeah, which is causing the snoring.
No wonder I can't sleep on my back. I literally can't sleep on my back.
Yeah, most people with sleep apnea sleep on their sides.
Yeah.
They have better quality of sleep when they do that.
Interesting.
Yeah.
That I don't know what's so funny out there. I got the All-Star panel out there making fun of us when we're trying to get some people some quality sleep out there. All right.
I think she may be lining you up for a sleep study.
I know, right? Hook up the leads. I'm ready to go. That's great information out there, folks. For those of you, for most of us, who for one reason or another can't sleep well at night. I don't know why. There's a lot of other reasons people probably can't sleep at night. Noise, light. Whether they've had a couple of pops before they go to bed.
Yeah.
Whether they've had caffeine before they go to bed. So, taking all that into account, you should probably back all of that out of the equation before you determine that all of a sudden you're suffering from sleep apnea.
Yeah.
Anyway, Justin has brought us some great information this morning. He's done a great job taking over for his colleague Doc Whaley while Doc and Jane are moving their way through Russia. I don't know where they are today. I don't know if they've got an audience with Putin this morning or what. But Jane is probably going to bring back a gold and jewel encrusted crown. She is queen, so Doc will tell us all about that when he gets back. So tell us who we're representing today again. We're representing the Georgia Cancer Specialists affiliated with Northside Hospital.
That's it.
Did I get that right?
You got it exactly right.
Justin, I've enjoyed being with you this morning.
I appreciate it.
It was a great segment, good questions, and when we come back, we're going to bring in a modified version of our All-Star panel. Jane's not with us this morning, as we've said about 150 times already. Cindy is going to be substituting for Jane. We've got Bruce with us today. So the three of us are going to tackle the problems of the world and see if we can make any rhyme or reason out of what this country's becoming. So Josh, I appreciate you this morning. Take us to break, please.